So case number 51 is about your crossbite, reverse bite, and how traumatic it can be, what is the treatment. And the second case that we will discuss today is your case number 53 from New Odell, which is about apparently a localized periodontal lesion, but upon investigations, it will turn out to be a systemic condition. So we learn about various systemic conditions which can mimic periodontal diseases. So to emphasize on these two cases, I want to clarify one thing first. When you're reading this also for the exam preparation, that in depth, never the orthodontic treatment is asked much in detail, but because you will also read in this case that some reverse overjets and some crossbites can be corrected by general dentists in general dental practice and also without fixed orthodontic treatment. So that is why ADC has been, whenever ADC has been asking you orthodontic questions, they are only related to the orthodontic treatments which are performed in general dentistry and by the general dentist. So crossbites actually come into that category, and that is why it's still important for the exam. Otherwise, rest of the ortho is really not important. But yeah, whatever a little bit of ortho comes, it comes as a form of MCQs regarding your little bit of landmarks on cephalometrics, and mostly the treatment of your crossbites, which should be detected as soon as possible by a general dentist, and the treatment should be started. So in that terms, the crossbites are extremely important, and the entire chapter when you read from model is not having the relevance as much for the exam, and that is why when we approach these two cases, I will not be like completely reading everything and going and taking you through and elaborating on every point given, because that is not extremely important and that is not relevant for the exam much of the part. So I'll be mostly taking it up as a brief review, and in between, I'll explain whatever gets asked in the exam from the related topic. Now, when we go to the next chapter, which would be your localized periodontitis apparent lesion, there is a complete table of possible conditions which might mimic periodontitis. That also we'll just briefly brush through. We don't have to really mug up those conditions, but when we do the MCQs and when we're reading about the questions systemically affecting disease, we'll briefly brush through them, because ADC doesn't really ask you in depth of all the systemic diseases that appear as periodontal disease. They would like you to know the names at least, so you can at least frame out a differential diagnosis, and there would be histological aspect of that systemic disease also, which is completely irrelevant from the exam and beyond the scope of the exam. So we'll be leaving behind few things, and it would be like a buffet. So we'll be picking up what needs to be done for the exam, and we'll be leaving what is not very relevant for the exam, because what is not is like beyond the scope of the syllabus. So we'll not go in depth with that. So this is going to be the approach when we take ahead these two cases today, and we shall start with case number 51 and move on to case number 53 then. So I'm beginning with 51. So although the complete management may not be important and the complete cephalometrics and orthodontic classifications may not be important here, but please understand that anterior crossbites or posterior crossbites are hot favorites. Whenever a little bit of ortho gets asked, it is mostly coming from your crossbites. And as a general dentist, you are equipped to identify it, you're equipped to treat it also. So a little bit of diagnosis we learn about anterior crossbites today, and we'll also go on and talk about the management part. So this is a mixed dentition patient, and it is extremely important to identify crossbite, especially in the mixed dentition, because that's when the growth of the jaws is taking place. And if there is an unaddressed crossbite, then it can actually lead to compromised growth of maxilla, because it would be retained because of reverse overjet, and it can actually lead to skeletal discrepancy. So when addressed in time, you can actually address and you can actually prevent the incomplete growth of a particular jaw, especially maxilla. So maxillary deficiencies can be prevented. So it's a 10-year-old male patient who presents with a class 3 incisor relationship. He's in mixed dentition, and there are signs of tooth wear affecting the front teeth. Now, the tooth wear is seen in the front teeth because crossbite not just hampers the growth of the maxillary jaw, but it also is a traumatic bite. It puts excessive load on the anterior incisors, and thus you can see even premature wearing off pattern in those teeth because of the edge-to-edge and the excessive tensile forces acting because of the reverse overjet. So that's also a traumatic bite and also leads to maxillary jaw deficiencies. So these are the kind of drawbacks that you would be seeing because of a crossbite, which makes it more importantly necessary to treat it in time, diagnose it in time, and treat it in time. So when you read this chapter today, I will be highlighting some points which are directly asked in the exam also. So I'll put a star next to it so that when you're watching it also, when you're revising it also, you know that these concepts are actually asked in the exam as well. So the patient complains about an uncomfortable bite and that the front teeth are meeting the wrong way around, because the lowers are supposed to be behind the anteriors, upper anteriors, and in this case it's the wrong way around, that the lower anteriors are ahead of the upper anteriors. The parents report that he developed a class 3 malocclusion after the upper and lower permanent incisors erupted and came into contact. Patient is otherwise medically fit and well. Patient presents with a mild class 3 profile when his posterior teeth are in maximal intercuspation. Now, you should know and learn the differences between retruded contact position and maximal intercuspation. In the ortho files also, I will be teaching about these concepts, and I'll briefly explain you again about the treatment of frostbites as well. But let's use this case as an opportunity to create a base around frostbites together, so that when we move to the ortho file, you already have a solid base over most of the ortho questions that's going to be asked in the exam. So this chapter sums up almost everything frostbite related gets asked in the exam. So you are done with this case and you're sorted for the exam. That's how good and efficient it's going to be. In fact, this case has a little bit of extra information which is not important for the exam, so we can just ignore that for a while. But otherwise, from the exam point of view, it completely trains you from whatever crossbite information you need to take up your sleeve that day. So the patient presents with a mild class 3 profile when the teeth are in maximal intercuspation. Now, maximal intercuspation is a centric occlusion, right? It is a centric occlusion. That's when your teeth are in complete occlusion, right? There is maximal intercuspation. They are not like lying cusp to cusp or edge to edge. They are in maximal interdigitation amongst the cusps. So that is called your centric occlusion, or also known as your maximal intercuspation. So these maximal intercuspation or centric occlusion not necessarily coincides with the centric relation. Do not confuse this one with centric relation. The centric relationship, whereas, is the most posterior position or the most posterior location of the mandible. Right? So your mandible cannot be pushed behind it practically. That is the most posterior position of mandible compared to the maxilla. So it is a TMJ related position. It is also dictated by the muscles and TMJ. And usually in healthy patients, centric relation and centric occlusion should coincide. Even if it's not coinciding, there should be some difference of 0.5 to 1 millimeters, mostly coinciding. So centric relationship is also known as your retruded contact position. So that means retrusion. Mandible is in complete retrusion as posteriorly as it can get. and teeth are making contact. It doesn't matter whether this contact is maximal intercuspation or not. That's why it's known as a retruded contact position, where the mandibular teeth meet the maxillary in the most retruded position. So I assume now you get the difference between maximal intercuspation, which is also your centric occlusion, and also know the centric relationship, which is also defined as retruded contact position. So these are two different things. Centric is your maxillary intercuspation, and centric relationship is your retruded contact position. So you use MI and RCP, maximal intercuspation and retruded contact position terms in orthodontic diagnosis, and not centric occlusion and centric relationship. Centric relation and centric occlusion is mostly used with prosto work, like when you're doing the CD fabrications. So when you're asking the patient to take the mandible back, and that's your centric relation reporting. When you're doing the teeth arrangement, you're giving a centric occlusion. So you're using these two terms in terms of your FPDs and CDs and indentate patients, right? When defining occlusion. But when you're defining and diagnosing malocclusions in ortho, because it's in terms of a bite, that's why you're asking or using the terms retruded contact position of the mandible and maximal intercuspation position of the mandible, right? So do not get confused in the exam if you read these different terms. You should be equipped and you should understand all these terms. I hope I made myself clear, and any confusion around these terms is sorted now. Now, going to your intraoral examination, the patient can achieve an edge-to-edge incisor relationship. What does this also mean? Clinically, not asked much in the exam, but I'll tell you one important relevance of this edge-to-edge relationship. So if you have a reverse overjet, like a patient has a class 3 profile, and if you ask the patient to try to achieve an edge-to-edge, can he take the mandible back and can he make the incisors neat? So that means clinically, if an edge-to-edge can be achieved by a class 3 patient, that means you can treat this patient without surgical intervention. That means it is not a severe class 3 and it can be treated with a conservative approach, like with either with a fixed ortho or with a removable ortho, but without requiring surgical correction, right? That means the skeletal enlargement of the mandible is not so ahead that you cannot take it, patient even if it tries, he cannot take bite in edge-to-edge. That means there is a severe class 3. So there is a clinical relevance to this point when you ask the patient that can he achieve edge-to-edge incisor relationship. This shows that yes, it is treatable conservatively and it's a mild to moderate category rather than serious one. There are signs of tooth wear attrition affecting the upper incisors, particularly the upper central incisors. Patient then postures forward, the so-called displacement. Another important orthodontic term, like maybe when patient bites, everybody naturally bites in centric, right? Naturally, everyone would first bite in centric, and that would be the retruded contact position. But this, as soon as the patient takes and bites in retruded contact position or in centric relation, immediately, because his cusps are not getting interdigitated correctly, so he finds the urge of displacing the mandible. So that is why he comes forward and the mandible comes forward, and then he achieves a comfortable bite where the good complete interdigitation and contact between the posterior teeth is achieved. That is a maximal intercuspation. So class 3 patients, when they bring the because of their class 3 profile, because of the reverse overjet, they're actually biting into a comfortable bite where the maximal intercuspation is achieved. That is not the centric relationship of the patient, right? Now in the UK, there is a classification of these cross bites, which is not important for the exam, so we can leave that. Now, what are the possible causes for class 3 malocclusion? Now, the potential causes of class 3 malocclusion is one, where there is unusual eruption path of the upper incisors, which leads to a forward mandibular displacement. Now, this happens when it is also kind of your pseudo class 3, where the upper incisors, they were retroclined, they were palatally erupted, they were interfering with the complete intercuspation at the central relation, and that is why due to forward mandibular displacement, now the patient is able to achieve maximal intercuspation, so he's habitually biting into a displaced position of mandible. So neither was his maxilla deficient, nor was he having an abnormally large mandible. Right? There was no skeletal cause to this class 3. It's a habitual class 3 because of displacement, mandibular displacement, because maximal intercuspation, occlusal interferences did not allow these maximal intercuspation at retruded contact position. Does that make sense for everyone? Right? So if the maximal intercuspation is not happening, is not coinciding with your retruded contact position, that means it's a habitual class 3 because he's trying to bring out the mandible and create a maximal intercuspation without having any skeletal class 3. But if it's a true class 3, when would it be? Like maxilla was already small and mandibular was abnormally large, right? Either maxilla was abnormally small or mandible was abnormally large. These two are your true class 3 skeletal relationships. What happens in this situation? Mandible is not coming out because of habit or because of any interference or getting displaced. It is coming forward because your centric relation and maximal intercuspation would be same there. So MI and RCP would coincide. They would be same. That means the patient is not displacing the mandible. The mandible is so big that when he bites in centric relation, maximal intercuspation is achieved and mandible is still ahead of maxilla. That is a true class 3. One would be a pseudo or habitual class 3. 2 and 3 would be true skeletal class 3. I hope the classification is also making sense now. And we totally have an SBQ on the same habitual class 3 relationship in the exam. We have an entire SBQ. Recently, it is not getting repeated in the exam, but it's there in the past paper. So for you to go through this concept is really important. So true skeletal class 3 and a habitual class 3. I hope you've got the difference between two now. So one is where MI and RCP will not coincide, and 2 and 3 or MI and RCP will coincide because there would be no displacement. Now, an OPG or an upper standard occlusion should be taken for planning orthodontic treatment. This will enable the practitioner to exclude the presence of supplemental or supernumerary teeth in upper anterior labial segment, which can actually lead to retroclined eruption of the primary as well, or the permanent as well. So a lateral ceph may also be considered if a significant skeletal discrepancy is diagnosed clinically. If there was no displacement, when do you suspect skeletal discrepancy? That means when there was no displacement, that means your MI and RCP should coincide. That would be your skeletal discrepancy. In this case, if it is not meeting because he can bite in centric and then he's bringing it forward, that means it's not a skeletal cause, it's a habitual occlusal interference cause. And if the reverse overjet is greater than 2 mm, then also you can suspect a skeletal cause, right? And that should trigger a referral to a specialist. For now, this case, MI not coinciding with RCP, it being a habitual displacement, as a general dentist, you can manage it. Radiographs can still be taken by a general dentist. The choice of treatment depends on the underlying etiology, as discussed below. Now look at it. This is upon taking the mandible backward, RCP or centric relationship. On centric, see, there are certain, these anteriors are causing interference. That's why the posterior are not interdigitating, right? This is an interference. This is an interference, and this is lack of intercuspation at centric relation, right? And now after that interference, mandible habitually comes forward so that the posteriors can meet, and that's where the patient finds comfort. That posteriors gain the complete interdigitation. You can see from both sides, now they are interdigitating, and you got a reverse overjet because of that, a cross bite. I hope his pictures are making itself clear, and the MI and RCP concept is also clear for everyone. Now, what is the camouflage orthodontics? Camouflage is defined as leaving a positive underlying skeletal discrepancy untreated. So if there was difference between maxillary and mandibular growth, say mandible was a little in excess or maxilla was a little in deficiency. So without treating the skeletal discrepancies, you just try to mask and correct the overjet with your fixed orthodontics or your removable. That is your camouflage orthodontics. In your mild to moderate cross bites, you can correct it, but in severe ones, you might require surgical correction and to correct the jaws discrepancy as well. But when you're going with the conservative method, minor skeletal discrepancies in those cases, it can be achieved by using either sectional fixed appliance or by upper removable appliance. And partial upper fixed appliances can be used, where also known as 2x4 appliances. It is not relevant for the exam, fixed orthodontics. But treatment usually of short duration in the mixed dentitions that aims at correcting etiology of malocclusion is known as interceptive treatment. Suppose this is another kind of treatment, and it is done mostly by use of your headgears. If you have identified in mixed dentition that the jaws are growing abnormally, like maxilla is deficient, or you see that mandible is overgrowing, so you have identified it, the etiology has been identified during the growth period, and if you try to correct the etiology, you're trying to correct the cause, you are not correcting it surgically later, you're trying to correct the etiology, you're trying to channelize the growth of the jaws in a correct manner. That is known as your interceptive treatment, and that is used done mostly with your headgears. So in mostly your class 3, you use your reverse pull kind of headgears, where the headgear is worn in front of the face, and a reverse pull is used, where you're actually pulling out the maxilla and using a chin cup, which forces or stops the growth of the mandible if it is growing excessively, and kind of pulls off and uses a traction force forwardly on the maxilla to bring it and help it in a forward growth, right? So that is the use of headgear, and in your class 3, you're using your reverse pull kind of headgears. Now, comprehensive early treatment for class 3 malocclusion. Correction of the skeletal discrepancy can be attempted with a face mask, that is a headgear, which is worn in front, which is a reversible headgear, in the mixed dentition, or by using a fixed appliance in a permanent dentition. So if you're doing it in permanent, then jaw surgery may be required. That would be done after completion of complete growth. But in the mixed dentition, if you have identified there is a jaw discrepancy, you can use interceptive orthodontics by using reversible headgear. Okay. Now, correcting a mild skeletal discrepancy in the mild dentition by using a face mask is successful in approximately 70% of the cases. Appliance design. Now, if you don't go, so like in this particular case, it is not a skeletal cause. He can take it edge to edge. You can notice that MI and RCP are not coinciding. And he has a habitual displacement kind of class 3. So what should we do? We can also give a removable appliance. And this is relevant for the exam. So I'm giving you this age criteria and the treatment that you may do. So the treatment for single teeth frostbite, or in this case, like an anterior section frostbite, if it's a growing patient, but in this case, he's 10-year-old, so teeth are completely erupted. If the teeth are completely erupted, then you can use a Hawley's appliance, removable appliance, with a Z spring. Z spring is going to push the teeth from the back and bring it in a positive overjet. If the teeth were not completely erupted, so if tooth was still erupting, right? Tooth was erupting in frostbite. Not erupted, but still erupting. Then you can use an inclined plane, or can use a tongue blade, because it's still erupting in retrocline position. So to prevent such interference, you can actually prevent the complete formation of frostbite by using an inclined plane or tongue blade. So completely erupted, and mesiodistal space is sufficient to move the tooth forward. Like in this case, if you look at it, the tooth, the mesiodistal space, there is no crowding. If you just created a gap, this tooth can be pushed out. There is no crowding. There is no interference from any adjacent tooth mesiodistally. There is no crowding, which will interrupt the movement of the upper incisor in a buccal direction. So if mesiodistal space is intact and not crowded, then Hawley's appliance. But if the mesiodistal space was crunched or there was crowding, the adjacent teeth were overlapping, then you would use fixed appliance therapy, because you will have to create the mesiodistal space for the tooth to move forward. So fixed appliance therapy in case of crowding, then the mesiodistal space is sufficient. There's no hindrance to the tooth to move forward. Then Hawley's appliance with Z spring, and the tooth which are still erupting, inclined plane or tongue blade. Right? Is that correct? Makes sense for everyone? These are the 3 different situations and 3 different treatment options. Now, in this particular case, the mesiodistal space is sufficient, and there is mixed dentition still, but the teeth is completely erupted because its age of the patient is 10. So you would require a Hawley's appliance with Z spring. Right? Now, the appliance consists of an active component, a retention component, and a base plate. So a large Z spring is used to procline the upper central and laterals. That means you're proclining them, you're buccally pushing them, and by eliminating the displacement, because there would be no interference then later on upon biting on the RCP, restorative contact position, and there would be no displacement. This is an active component. Alternatively, you can use T-spring also, or these are spring designs. Then Adams scrib on deciduous molars and molars are used for retention. And you will have to add a posterior bite plane, a little bulk on the posterior teeth to raise the bite, to open the bite, which will allow the anteriors to move forward. Because without you raising the bite, there is a negative overjet, so lower anteriors would hinder the forward movement. So you'll have to raise this bite so that these teeth get disengaged, and then your maxillary teeth move forward. Right? So a bite plane is also required. This is the appliance design, and these are the pictures after regaining the overjet and pushing the teeth forward. So you have seen that you have a positive overjet now, and upon centric biting, the patient is able to achieve maximal intercuspation also. Now, the appliance is usually worn full time for a period of 6 to 8 weeks. Although the duration and the complete appliance therapy is not asked, they're always asking you what kind of treatment is what you will be doing. So they're not asking you the duration, but it's good to know a little bit extra. So 6 to 8 weeks is the one time, followed by nighttime wear for approximately 3 months. There's a posterior open bite once the upper incisors have been proclined, as seen in the images provided, and this will settle and teeth will supra-erupt and interdigitate, and then the maximal intercuspation would be achieved in the centric relationship. So this is also a good example of interceptive orthodontic treatment, because here the cause or etiology was occlusal interference and not your skeletal discrepancy. So we are not going for face masks or headgears. In fact, here the etiology was occlusal interference, which has been eliminated by pushing the anteriors outside. You have to take the consent from the patient. It is all UK guidelines, so not relevant for the exam. Legal issues, etc. Also, patient adherence to wearing, maintaining the removable appliance may be an issue in some cases. It is important to remember that most appliances are not worn for the time requested by the orthodontist, and some microsensor technology can be used to monitor wear, although this technology is not infallible, and patient consent should be obtained when monitoring devices are used. Not relevant, absolutely. Now, this is after completely proclining the anteriors. There was likely some gap in the posteriors, and there was an open bite posteriorly, and because now anteriors are interdigitated, this open bite posteriorly has been corrected by supra-eruption of the teeth. So they have supra-erupted, and complete maximal intercuspation has been achieved. What are the prognosis and factors for the retention after the treatment of this upper arch? Well, if anteriorly you are creating a good overlap, which is a complete, so you have corrected the overjet, but you also need to get some overbite. So this overbite is also required. Why this overbite is important? This is your vertical overlap. Horizontal overlap you have corrected, which was negative first, but the vertical overlap is also really important, which is the overbite, and that must be totally achieved because it acts as a natural retention. So these teeth will not tend to move back palatally because of a natural stop in form of lower anterior teeth. So this needs to be achieved at the end of this treatment, otherwise a relapse may occur. So if you are only proclining them, but there is no vertical overlap, then these teeth will go back forward. So you need to have an overbite for these teeth to act as a stop and act as a retentive feature, right? Patient needs to be advised that continuation of existing growth patterns can later also jeopardize the orthodontic treatment outcome in long term. So later on also, if mandible continues to grow in excess or maxilla remains deficient and mandible continues to grow in a normal pattern also, then the crossbite can recur as well. So there can be still some jeopardy related to the treatment, and that is why a complete follow-up later on also is required. So bite for this patient remained stable for long term and no further orthodontic treatment was required. That means both jaws grew in a normal pattern and there was no skeletal discrepancy. But teeth and anterior crossbite can be treated in the mixed dentition by using your interceptive ortho. This type of treatment can be simple and cost effective. The need to comply with removable appliance wear needs to be made clear at the start of the treatment. Progress needs to be monitored and documented carefully. Obtaining the patient consent regarding long-term prognosis of class 3 is also important. Growth cannot always be favorable. The mandible tends to grow for a longer period compared to the maxilla, and that is why there is a potential for it to relapse. Usually that will happen only when there is skeletal discrepancy. Otherwise, usually it would not relapse. And other method of preventing relapse is by creating the vertical overlap. That is extremely important because otherwise these orthodontic movements tend to show relapse as well. And this vertical stop or a positive overbite will totally prevent that, right? So that would be the end of this case, and we'll be starting with the next case now. So we begin with case number 52 now, which is localized periodontitis. So it's about a 30-year-old male who's referred for periodontitis that has not responded to treatment. What is the cause and how would you proceed? So this is the IOP radiographs of the upper and the lower teeth, and we can notice that there is a radiolucency, which is involving the first molar. If I showed you the border, then it is a diffuse radiolucency going from your first molar also over the second molar. And also for the lower premolar area, it is involving the first and the second premolars. You can see it as a radiolucent shadow, which is looking like a buccal or a lingual plate bone loss rather than the mesial or a distal one. Now the patient complains that he has been undergoing intensive treatment for gum disease, but with little success. His upper right first molar is slightly loose now, and his dentist wishes to extract it. He would like a second opinion. He noticed the gum disease 9 months ago. He has never had pain or discomfort from the tooth. The patient is a regular attendee at his dentist's clinic. He has no dental restorations, no caries, and no other oral problems. The previous dental practitioner had provided intensive oral hygiene instruction, root surface debridement under local anesthesia, and reassessment as well. The patient brushes twice a day with a fluoridated toothpaste, uses interdental brushes of 2 different sizes, as well as flosses daily as well. Patient is medically fit and well. He has no allergies, takes no medication, has never smoked. And so what are your initial thoughts? Well, periodontitis is often difficult to treat, and many patients are not able to maintain a sufficiently effective oral hygiene regime or have other risk factors that have not been controlled or are beyond control. It remains possible that this patient is not cleaning effectively regularly despite his efforts, and this must be assessed. Or perhaps previous treatment did not completely remove all the etiologic agent like your subgingival calculus. Assuming the previous treatment was optimal, there has been sufficient time for the non-surgical treatment to have had some effect. Upon extraoral examination, the results of extraoral exam are normal, no lymph nodes are palpable. And on intraoral examination, one lower third molar is partially erupted, upper third molars are unopposed and distally inclined. There is no dental caries, no restorations present. The patient's oral hygiene is very good, only a few flecks of interdental plaque are present. Gingiva in most areas are healthy in appearance and do not bleed on probing. So there is no generalized gingivitis or any kind of etiologic agent present like plaque or calculus. On full clinical periodontal assessment, only 3 areas of concern are identified. One is the upper first molar region, the lower second premolar, and also on the lower left second molar. So upper right first molar is mobile, about 1 millimeter in the bucco-palatal direction. It is grade 2 mobile and it is not having any vertical component or depressibility in the socket. A 9 millimeter probing depth is present distopalatally, and a distal furcation has grade 2 furcation involvement. The gingiva appears loose, but they are not edematous or red or inflamed, and there is only slight bleeding on probing. So considering the amount of destruction of bone, the gingiva does not replicate the picture of inflammation. Gingiva shows very minimal amount of inflammation. Inflammation, whatever is, there is diffuse rather than being related to gingival margin or pocket. Gingiva also is easily liftable from the entire tooth. Now the lower right second premolar also has a deep probing depth, which is 5 mm distolingually and 4 mm mesiolingually. So again on the lingual aspect, upper also distopalatal, lower also lingual aspect. Tooth is not mobile, gingiva are dusky red, not edematous or inflamed, and are relatively firm, although slight bleeding on probing, which is also seen subclinically in most healthy gingiva also, is found. Then there's again a deep pocket on the mesiolingual aspect of the lower left molar, again the lingual surface involved, no bleeding on probing. Root surfaces on all these areas feel smooth on probing. That means the root surface carry no irregularities or no calculus depositions if it's feeling smooth from the probing pattern. So what other investigations? What do you see in these 2 IOPs that the patient's general dental practitioner sent? So the upper radiograph shows extensive bone loss distal to the first molar. There is loss of lamina dura around the whole of the distal root into the furcation and around the apex. Calculus is not visible. The lower film shows a curved area of alveolar bone loss associated with first and second premolars. Lamina dura and alveolar crest on the both teeth appear intact. The bone loss is consistent with the probing depth, no calculus again. So there is no etiological agent, but there is periodontal destruction. And there is no gingivitis or inflammation characteristically seen in gingiva, but definitely bone destruction, no etiological agent, and no gingival inflammation. These are your most important findings, and there is gross bone destruction around these teeth. The vitality of upper first molar must be determined. Bone loss extends beyond the apex, and there is a significant risk of loss of vitality. The apical lamina dura is not clearly defined, particularly in relation to the maxillary sinus, giving rise to further suspicion. A radiograph is needed to appreciate the bone levels around the lower left molars and possibly those around other teeth as well. However, before selecting a suitable view, further thinking is required, and in the meantime, you check the vitality of the upper right first molar as well. It is vital and not hypersensitive to cold and electric pulse testing. Now, what are your thoughts? Well, this is odd. The patient is motivated and his oral hygiene is good. However, there are 3 areas of localized periodontal destruction, and these cannot be accounted for by local factors such as overhanging restorations or calculus. So absolutely lack of any etiological factor for now. Perhaps the patient has progressed form of molar incisor pattern periodontitis, which is defined as rapid attachment and bone loss occurring mostly at a young age, sometimes also having a familial pattern. And the sites of lesions on 2 first molars and 1 premolar, and the age of the patient and failure to respond to the treatment is also projecting towards that molar incisor pattern periodontitis, which is also your aggressive periodontitis. Now, would further non-surgical periodontal treatment with adjunctive antibiotics help? So perhaps the patient has some systemic predisposition to periodontitis. The most likely cause would be And the biggest risk factors for your periodontitis are diabetes and smoking. And ADC loves you asking about these risk factors and concerning periodontal conditions. So I will be sharing the articles where we'll be reading and understanding more on periodontitis related to diabetes, periodontitis related to smoking, and I will be sharing them after the class on the group also. You can start reading periodontal articles. I will be sharing quite a few periodontal articles. Reason being, periodontitis is extremely favorite with ADC, and all the time new questions keep getting asked in the exam related to periodontitis and its systemic risk factors. So I will also use those articles and teach you in the classes where we'll do MCQs related to periodontitis, and I will teach you what are the relationship and what are the conditions and how they affect this particular disease. So, however, diabetes would have to be undiagnosed or poorly controlled to contribute to this kind of severity. Both diabetes and smoking are associated with periodontitis in a generalized form, but not in a localized form. But very rarely they can predispose to a localized disease as well, especially periodontal abscesses. Diabetics and poorly controlled diabetics especially have localized periodontal abscesses also. Now, other medical predisposing conditions include neutropenia, Down syndrome, and some rare developmental neutrophil defects like Chiari-Higashi disease, all have predisposition to severe periodontal conditions. But these all become obvious in childhood, and then that's why easily can be excluded in this case. So you decide to go with an OPG because you're suspicious that there may be more areas affected because the pattern of the disease is unusual. And the pictures or the result is shown in this image. So this is the OPG of the patient. And on the right side, you can see that there is the first molar radiolucency, which was observed, is now also reaching the maxillary sinus and also going beyond up to the second molar. So it is diffuse and kind of eroding the floor of the maxillary sinus. If you see that floor of the maxillary sinus is here, till here, like here in the normal pattern. So it has been diffused and eroded. There is no floor of maxillary sinus, so it has eroded the maxillary sinus area. And in this lower jaw, you can see it is involving the premolars and going up until your posteriors. So the lower left third molar is missing. Lower second molar has a conical root morphology. There is a shallow angular bone defect mesial to the lower left second molar. Let's go and see that also. Check that out. So this angular bone loss, the vertical bone loss in front of the second molar is also seen. This certainly reinforces the suspicion of a molar incisor pattern periodontitis, which is your aggressive periodontitis, because that characteristically has the vertical bone loss rather than the horizontal bone loss pattern. So have you missed something? Go back and look again at the periapical and OPG radiographs and reassess the history. So what radiographic features are inconsistent or suggest alternative causes? The upper periapical shows a large area of destruction of bone, and it's poorly localized with the furcation appearing fuzzy. Bone around the apex and maxillary sinus is not clearly defined, but the tooth is still vital. If it was actually a true periodontitis, which is infected, which with such amount of bone loss and apex involvement, would have surely involved the endodontic involvement as well. So it would have become a primary perio and a secondary endo situation if it was a true periodontitis. And you would have gotten an abnormal result on pulp sensibility testing and an observable corticated sinus margin radiography. Now the same area of OPG shows much more worrying features. You had been concentrating on the periodontal condition and had not noticed the maxillary sinus above the tooth is indistinct. Floor of the antrum is eroded over the first and second molars. Compare this area with the contralateral floor of the antrum. There is a radiolucency above molar roots on the right and poorly defined upper border. The lower periapical view is also unusual. The minor dura and alveolar crest are visible between the premolars, despite the smooth rounded shape of bone loss adjacent to this. Therefore, the bone loss is not interdental, but is rather on the lingual cortex and extending across the two teeth. Lingual cortex is thicker than the buccal cortex, and infrabony pocket caused by periodontitis could cause such a defect. But more interdental bone loss would be expected because of periodontitis is usually initiated interdentally. So if it was true periodontitis, you would expect it to be more interdental rather than on the lingual cortex. So now that you have recognized the extent of the upper lesion, your suspicions are confirmed. This is not a true periodontitis, but rather some systemic disease having a periodontal manifestation. So what are the conditions which mimic plaque-induced gingivitis or periodontitis? Now there are various systemic conditions given on this table, and you don't have to memorize all the features, but rather know their names. And you know that because it's a systemic condition, some kind of more diagnostic tests would be required, and investigations would be required to confirm and rule out those conditions. So in the exam, these conditions and diseases will not be asked in detail, but you must know what are the differential diagnoses. So one is a granulomatous inflammatory condition, which can include your orofacial granulomatosis, oral Crohn's disease, Merkelson-Rosenthal syndrome, sarcoidosis. You don't really have to learn all the clinical features of these systemic diseases, but must know that they present themselves as periodontal involvement. They can have soft tissue involvement and the bony involvement as well. Leukemia is extremely important, so I'm making a star which is asked in the exam, so you at least can read that column. So leukemia usually presents in children with acute myelomonocytic or monocytic leukemia, or in older patients with CML, and they can give you lumpy gingivitis, few suspicious features like inflamed maroonish or greenish gingivitis, or one or more ulcerated growths from the gingival margin. Additional infectious signs of immune suppression, especially candidiasis, may also be present. And a biopsy, blood film, and history would confirm the diagnosis. Then you can have granulomatosis with polyangiitis, not really important, but you can have a granular or red, white speckled strawberry gums. This is asked as a MCQ. So Wegener's granulomatosis, also known as your strawberry gums, it is granulomatosis with polyangiitis. It also involves blood vessels, and that's why the blood vessels proliferate. It gives you enlargement. So Wegener's granulomatosis. Then hereditary gingival fibromatosis can give you gingival enlargement, and sometimes it can be generalized, and sometimes solitary forms are also seen, which are associated with some syndromes. There would also be some family history, and a biopsy would confirm that as well. Then autoimmune diseases, especially the lichen planus, etc., they can give you red gingiva, desquamated gingivitis. Then foreign body gingivitis, all these can also give you dusky, inflamed appearance of gingiva, but they would not have bony involvement. Then traumatic lesions like mechanical, chemical, and thermal, they can be present at any age. Chemical agents can be chlorhexidine, aspirin, cocaine, hydrogen peroxide. Mechanical can be overzealous professional cleaning, and then thermal can be burns from hot drinks or food. Then deposition diseases because of some metabolic disorders. So some metabolic byproducts getting deposited in the gingiva, and that could be your glycogen or mucopolysaccharide related diseases. Biochemistry, biopsy, family history will easily help you rule them out. So giant cell granuloma has two forms. One is giant cell epulis, which resembles fibrous epulis or pyogenic granuloma on the gingival margin, or it can have a central form like a cystic destructive form, which has a bony involvement. That they would not have any systemic features. Biopsy would totally be confirming that, because in a giant cell granuloma you'll find giant cells, and that connective tissue collagenous matrix in which dispersed giant cells would be found. Then a fungal infection like gingival candidosis can be seen, especially seen in patients who have HIV, and you can also have a lumpy granular inflamed gingival swellings in such patients, but this is an endemic disease and would not be found in this particular group, so a biopsy would also confirm that. Then a Langerhans histiocytosis. Now that can be a solitary lesion or can have multiple conditions, multiple lesions, destructive lesions, which mostly affect skull and jaws. It can arise at any age, destroys the bone around teeth, and in late disease, teeth appears to be floating in air radiographically because there is no bone that is remaining. And a biopsy will confirm that. Then an odontogenic tumor also from gingiva rather than in bone, and most cause a small nodule or they can also erode superficial bone, can be easily excised. The commonest odontogenic tumor to occur extraosseously is CEOT, calcifying odontogenic cyst, and squamous odontogenic tumor merits special mention because it sometimes arises in PDL or gingiva and can mimic periodontitis. And a biopsy would confirm such benign tumors. Then it can be a malignancy, squamous cell carcinoma of gingiva, and it's a rare site, although gingiva is a rare site because mostly it is seen on the floor of the mouth or posterolateral border of the tongue, and which usually would present in those patients who are 50 years or above. It can destroy soft tissues and bone, and biopsy would confirm that. And usually a malignancy is also linked with paresthesia. So if you have a bony swelling or if you have a radiolucency associated with the paresthesia, that would characteristically link it up with a malignancy. It can also be a metastatic malignancy rather than originating in the gingiva or bone or PDL. It can actually be a metastatic deposit of a distant malignancy. So most commonly the breast malignancies or the lung malignancies show their metastatic deposits in the jaws, especially posterior part of the mandible. And a biopsy and a history would confirm that. Then hypophosphatasia is an enzymatic disease which also leads to periodontal destruction. It is because of a genetic mutation and alkaline phosphatase enzyme is affected. So serum alkaline phosphatase levels and family history would also confirm that. So exam point of view, I'm putting the stars ahead of the lesions that are really important, and you can revise those. In this case, Langerhans is the etiology. And from the top, I've already marked the one which was most important. So these are the possible differential conditions which are systemic diseases or conditions which can actually do not originate as periodontitis but can mimic it. So what is your differential diagnosis on the basis of what you have seen so far? Because most of the conditions in those tables did not involve the bone and only few involved the bone and gave this destruction. That is why Langerhans, histiocytosis, squamous odontogenic tumor, and metastatic malignant neoplasm are the most likely differential diagnosis. Among these, the most common amongst the rarest is Langerhans cell histiocytosis. Although the tumor also meets all the criteria, but is rarer than the Langerhans cell histiocytosis, and metastatic neoplasm must also be considered, and a primary malignancy at a remote site is possible, but unlikely at this age of the patient. And multiple lesions, particularly in this pattern, would be unlikely. Mostly metastatic deposit is seen on the posterior mandible. Here we have both the maxilla and the mandible involvement, so we have multiple sites rather than a single metastatic deposit. So that's why that makes it a slightly less likely differential diagnosis. So what will you do next now? Because all these three conditions which you are putting on differential diagnosis can be easily ruled out on the basis of histology. So you would require a biopsy. Would be required to achieve the correct diagnosis for any of these diseases. Gingiva is readily sampled under the LA, and the best site would be the soft tissue from the margin of either of the larger lesions. The lower premolar or the upper right molar, the buccal interdental papilla would be ideal. It would probably be best to extract the affected upper molar tooth. It has lost most of its supporting bone, and obtaining the correct diagnosis is a greater priority. In any case, the prognosis for this tooth is poor, and its removal would allow good access to the deeper tissues to obtain biopsy sample. The socket can be curated to obtain additional material from the alveolar bone, but keep in mind that there's a risk of accidentally having an oroantral communication. So now the biopsy sample is shown, and you don't really have to learn the characteristic of Langerhans cell. I'm just showing you the slide, but in any ways, this is beyond the scope of ABC syllabus, so we are not reading and learning the characteristic histological features. This is the gingiva sample, the sulcus, and this is where these neoplastic cells are seen. And these are your eosinophils, which are marked E, and these are your Langerhans cells, which are multinucleated cells. So on confirming from the diagnostic sample, the diagnosis is Langerhans cell histiocytosis, and it is a dendritic cell found in epithelium. These cells develop in bone marrow from the monocytic lineage and migrate to the epithelium of the skin and the mucosa, and then there they reside to present external antigens to the immune system. A clonal proliferation of Langerhans cells presenting as a spectrum of disease severity. All types have a predilection for skull and jaws. Lesions are painful or asymptomatic and can also accompany soft tissue swelling. Patient has multifocal single organ system disease because only bone is affected, no other organs are involved. So he has multifocal, that means multiple swellings, but only single organ is involved. Right? So the types are multifocal and multi-organ, then multifocal and single organ. Another is unifocal, so only one solitary existing condition. So this is a acute form, this is the fulminating type, and it's mostly fatal before the age of 5. It affects multiple organs, it can affect skin, liver, lymph nodes, bones, spleen, and all, and usually requires aggressive treatment with chemotherapy. It is a malignant neoplasm of Langerhans cell. Multifocal single organ is usually the benign one, and usually when the pituitary is involved, diabetes insipidus would develop with exophthalmoses and bone lesions. It would call Hans-Schiller-Christian triad or syndrome, and usually when you are treating it, curettage of the lesions and sometimes maybe chemotherapy adjunct would be required. And unifocal disease, where there is only just one single lesion, solitary kind. So these solitary lesions have a benign course, and curettage is usually curative. So the most fatal one is the fulminating kind, which is the multifocal multi-organ disease. And then multifocal single organ has moderate prognosis, curettage and chemo both are required, and the unifocal only curettage is required. So this patient is the type 2, which is multifocal single organ. Now, what treatment is recommended? You would take a radiographic survey of the skull together with a bone scan or skeletal survey to identify any lesions anywhere else as well. Medical exam and a detailed history are required in case of soft tissue involvement. Lesions in chronic multifocal disease and solitary granulomas, they usually respond to curettage, and this will require you to remove the upper right first and second molars to gain the access and do the complete curettage. Then all the involved soft tissue should also be excised. There is, however, a risk of oroantral communication. The lower right premolar region may be curated without tooth loss, but the surrounding presumed affected soft tissues must be removed and may result in tooth loss. A more conservative approach may be possible if the patient accepts the risk of recurrence. Any recurrence could be, again, recurated as well. The lower left molar lesion could have been caused by periodontitis and requires biopsy for treatment planning. Long-term follow-up is required. Lesions may recur and new lesions can develop over a period of many years. From the medical legal perspective, this case highlights the particular importance of thorough and systemic radiographic reporting to observe any unusual abnormalities, which should be sent for immediate referral for specialist investigation and further management. Fortunately, these type of conditions are rare, but delayed referral can have legal consequences, resulting in significant morbidity and mortality also for the patient. And especially in case of neoplastic lesions, if he had a multifocal multi-organ type, then it could even turn fatal for this. So the overall crux of this chapter is that it's not like that prime highlighted ABC relevant, out there topic. And ADC is not going to ask you, give you a periapical radiolucency or a periodontal bone loss, and the final diagnosis would be Langerhans. There would not be such direct SVQ or MCQ in the exam, but it can be a base of certain questions, and it can give you an insight that when you're suspecting a radiolucency, you should keep your brains and eyes open, that it could also have some other systemic disease reflecting itself or mimicking the periodontal disease. So basic purpose of doing this case was to understand that there are certain conditions which can mimic periodontitis. So sometimes ADC can actually give you a single question or a single radiograph and can ask you what could be the differential diagnosis of it. So you must know that these conditions can also present like that. And because periodontitis is hot favorite, anything even at the edges of periodontitis, anything at the edges and boundaries of periodontal disease and medical history and a systemic disease can still be asked in the exams. Chances are less, but because we're aiming for a super preparation rather than just going to the point, so this chapter actually opens up your perspective to other possibilities which can mimic periodontitis but are actually systemic conditions. So correct referral and diagnosing them in time so that it doesn't lead to mortality or morbidity in the patient, you are playing a big role in immediate early diagnosis of certain conditions, right? So that's the relevance of doing this case, and I hope it makes sense and served its purpose.